Welcome to this explainer. For the neuroscientists, psychiatrists, and advanced meditators tuning in, we are cutting straight to the chase today. We're going to rigorously deconstruct the exact neurobiology of OCD and map out precisely how targeted contemplative practices physically restructure large-scale brain networks.
For decades, the prevailing clinical dogma basically blamed localized basal ganglia and frontal cortex abnormalities for OCD. We had this classic CSTC loop model, cortico-striothalamo-cortical, which pointed to a simple imbalance of excitatory and inhibitory pathways. But let's be real, contemporary neuroimaging demands a total paradigm shift. We can't just look at localized hyperactivity anymore, we absolutely have to look at large-scale network dynamics.
Here is our roadmap for today. We'll start with the triple network model, isolate the posterior cingulate cortex, and then systematically break down the neurophenomenological mechanics of mental noting and vipassana.
Section 1. The paradigm shift. Moving from localized circuits to complete network failure.
When you look at the triple network model, it becomes incredibly clear that OCD is fundamentally a failure of the Salience Network's toggling mechanism. Normally, your Salience Network, anchored in the dorsal ACC and anterior insula, detects a stimulus, right? It then uncouples from the internal, self-referential default mode network and fires up the executive control network to handle it. But in OCD, due to some really profound insular dysfunction, that toggle just fails. The patient gets locked into a hyperconnected DMN state, so internal, obsessive thoughts are processed with the absolute terrifying vividness of a real external threat.
Section 2. The anatomy of obsession, specifically the posterior cingulate cortex.
When we really look under the hood at the default mode network, there's this massive integration center right in the middle. The DMN's central posterior hub, the PCC, is relentlessly fusing bottom-up sensory and attentional inputs with top-down memory and semantic concepts. To truly grasp this pathology, we've got to look at the highly heterogeneous subregions of the PCC. The ventral PCC is tightly coupled with the medial prefrontal cortex. It essentially drives your autobiographical self-view, that sticky I and me narrative. Meanwhile, the dorsal PCC talks to the executive control network, modulating physiological arousal and environmental scanning. So in an obsessive-compulsive brain, dysregulation across these specific subregions literally traps the patient. The ventral PCC is pumping out a rigid self-narrative, and the dorsal PCC is triggering involuntary arousal. It creates this relentless cognitive behavioral loop that feels as real and dangerous as actual external danger. Clinically speaking, this is the precise neural architecture of getting stuck in a thought.
Section 3. Neuromodulation via contemplative practice.
All right, let's shift gears. How do targeted contemplative interventions manually override the pathological neural oscillations we just talked about? The crucial takeaway here is that techniques like focused concentration and open monitoring don't just relax the brain. They systematically downregulate and structurally deactivate the primary nodes of the DMN, specifically the medial prefrontal cortex and that hyperactive PCC. It's an active, directly opposite neuromodulatory effect to the disease itself.
Section 4. Mental noting and prefrontal gating.
Let's get extremely specific about how this works in practice, starting with mental noting from the Mahasi Sayadaw tradition. Think about the 4 cognitive factors here: anchoring concentration, detecting the sensory event, maintaining a frictionless, non-efforting stance, and finding contentment or non-judgment. These are not just subjective spiritual instructions, they are highly precise neurocognitive tools for cognitive diffusion. But what is actually firing in the brain when a practitioner executes this sequence?
Well, when a practitioner silently applies a neutral label to an intrusive thought, saying internally, fearing, doubting, or itching, they are actively engaging the left inferior frontal gyrus for language processing, and at the exact same time, they recruit the DLPFC for top-down cognitive control. By bringing linguistic semantic labeling online, the brain actively decouples the thought from the raw limbic affect that's usually driven by the amygdala and insula. You're effectively bypassing the amygdala's threat response by forcing cortical processing. It gates the threat response and dampens DMN processing before full cognitive capture can even happen.
This leads to a profound phenomenological shift that we call decentering. By stepping back and observing thoughts as transient mental events instead of absolute truths, we trigger a direct neural correlate, a decrease in DMN microstate duration, and radically reduced functional connectivity in the very regions that drive thought-action fusion.
Section 5. Vipassana and choiceless awareness.
Now, while noting relies on top-down linguistic gating,
Vipassana somatic scanning and choiceless awareness operate through bottom-up open monitoring mechanisms. By anchoring attention in raw, high-resolution somatic data, like through systematic Vipassana body sweeping, bottom-up sensory streams interrupt default processing. And here is the wild part. Through intense practice, the PCC is essentially forced into functional coupling with the dorsal ACC and DLPFC. Because of this totally new coupling, the second DMN activity emerges, it automatically co-activates those prefrontal hubs to monitor, check, and suppress the interference. You're building an entirely new neural check and balance system.
We've actually seen this proven out in real-time fMRI neurofeedback paradigms. They clearly demonstrate that when a meditator detects a shift in attention, the dorsal ACC flags the anomaly, and the DLPFC immediately slams the brakes with top-down inhibitory control. This correlates directly with decreased posterior DMN activation, literally stopping the OCD cascade dead in its tracks.
Section 6. Wiring the new default mode.
So, we've mapped out the acute state effects. But what happens when you sustain these over time to build a new baseline? It takes surprisingly little time to start seeing trait-level changes. Clinical studies on mindfulness-based cognitive therapy, or MBCT, and acceptance and commitment therapy show profound neuroplastic remodeling in just an 8-week time frame.
Over those 8 weeks, massive structural shifts happen. Interestingly, rather than just totally silencing the midline hubs, ACT or MBCT actually restructures the resting state functional connectivity of the PCC and precuneus. It literally alters how these nodes talk to the rest of the brain. The connectivity between the left insula and left IFG gets significantly stronger, and this resting state alteration specifically neutralizes that sticky, rigid self-narrative we talked about earlier, allowing patients to observe highly distressing intrusions with deep cognitive distance and flexibility.
This day-in, day-out systematic practice drives continuous neuroplastic remodeling. It wires what psychological frameworks call the wise advocate, that mindful, objective observer, directly into the brain's basal ganglia, its habit and reward centers. You're basically installing a new pacemaking mechanism, a permanent guard against mental intrusions.
We can even measure the spatiotemporal properties of this remodeling. EEG fMRI temporal dynamics reveal that advanced practitioners fundamentally alter the microstate duration of their DMN. Crucially, this alteration correlates negatively with years of meditation experience, which proves something amazing. Distress tolerance and large-scale network flexibility aren't just temporary states of relaxation. They are permanent trait effects that can be structurally learned and wired right into the cortex.
I'll leave you with this final, provocative thought. We now know that baseline functional connectivity in the DMN can actually predict therapeutic outcomes for these modalities. Generic mindfulness apps can sometimes even worsen OCD by providing loose tools that get easily co-opted into compulsions. So, shouldn't we be looking toward a future of precision psychiatric care? A future where we use personalized fMRI mapping to surgically assign specific, neurologically validated contemplative techniques, like noting or Vipassana, to the obsessive brain? It's a fascinating frontier. Thank you so much for joining me on this deep dive in today's Explainer.